Welcome back, everybody. It is truly a privilege and honor to have our next speaker, Dr. Walter Chan, who's coming from Brigham and Women's Hospital, where he is the director of the Motility Center. He'll be speaking about esophageal manometry. He is also the director of another upcoming Harvard course, the Harvard Motility course. So for those of you who want to know even more, please stay tuned for that as well. And with that, I'll hand it over to Walter.
Thank you. Thank you, Kumar. First of all, I want to thank the organizers for inviting me to participate in this great course. It's a much needed topic, and it's great to get all the surgeons and gastroenterologists and everyone to take care of these patients together. And this morning, I'll be talking about esophageal manometry, indication, and how we interpret these studies and how they're relevant to clinical care of patients. I have no financial disclosures for this talk. So just a little bit basic about esophageal manometry. As we know, it's a study that we use a long catheter pressure sensors that we place transnasally into the esophagus and stomach of the patients in order to measure the motility and the different esophageal sphincter strengths. The current version of manometry that we use is a high-resolution manometry, which has 36 sensors, pressure sensors that are located throughout the catheter, spacing about 1 centimeter apart. Compared to the old conventional manometry, which only has 5 to 6 sensors, this gives us a more high-resolution image and measurement of the esophageal function. It also allows simultaneous recording from all segments of the esophagus. We don't really need to pull the catheter and reposition them to get all the different measurements. And it also allows us to more accurately localize all the anatomical landmarks. And with this high-resolution manometry, we can also interpret the pressure data in this color plot, which makes it easier to visualize. So what are the indications and role of manometry in evaluating foregut patients? First of all, we use it for the most part in assessing esophageal dysmotility, and also to evaluate for anatomical landmarks, like what the lower esophageal sphincter pressure is, what the diaphragm is, which can also allow us to measure the presence of a hiatal hernia. If we want to do reflux testing, like pH monitoring probe testing, the manometry can also help us properly place the probes to make sure that the pH sensor is located at the right position. When we are thinking about doing anti-reflux surgery or also some other foregut surgery, this is useful to help evaluate for any contraindications to surgery. In a study that we published about 10 years ago, we looked at 1,000 patients who came in for manometry for anti-reflux surgery. And in that, we actually identify about 5% of patients who have high-grade dysmotility, including achalasia. So it's important to incorporate this into a routine preoperative care to make sure that we select the right candidate. The manometry can also allow us to identify other etiology of a patient's symptoms. For example, conditions like rumination syndrome can be identified. And finally, there have been a lot of studies that show that manometry can have findings, can help prognosticate outcome of the surgery, and also any signs of postoperative dysphagia or other esophageal complications. So this is what a conventional esophageal manometry tracing looks like, where the pressure tracing on the top corresponds to the pharynx, in the middle is the esophageal body, at the bottom, the lower esophageal sphincter and the stomach. This is the older type manometry catheter, so there are only a few sensors in the esophageal body. But as you can see here, you can identify the basal pressure of the lower esophageal sphincter, as well as when it relaxes when a patient takes swallow. In the middle, you can see these contractions that propagate from the proximal to the distal esophagus, corresponding to esophageal peristalsis. Now, looking at the high-resolution manometry version of this, which is what we currently use, because of the high-density data, this pressure data is now converted to this color tracing, where warmer color represents higher pressure and cooler color represents lower pressure. And with this, you can see a high-pressure zone at towards the top of the screen, where it corresponds to the upper esophageal sphincter with relaxation when the swallow starts. The pressure zone towards the bottom corresponds to the lower esophageal sphincter. And then also these peristaltic contractions that propagate down the esophageal body during a swallow. So as you can see, this makes it much easier to visualize. Another feature that is now incorporated in manometry frequently is multi-channel intraluminal impedance. What impedance does is help detect intraluminal bolus movement, something moving within the esophagus. So what exactly is impedance? Impedance is actually a measure of resistance to change in electrical current when certain boluses pass by pairs of sensors along the catheter. So for example, liquid, which has a high conductance, also has a low resistance, hence a low impedance. So whenever liquid passes by these sensors along the catheter, you see a drop in impedance. And that will allow you to see when liquid passes by during a test. And this impedance technology can be either combined with manometry, where you can measure transit of bolus down the esophagus, or combined with a pH monitoring test, where you can measure bolus refluxing up. And for this talk, we're going to focus on talking a little bit about how impedance combined with manometry can help us in diagnosing patients with esophageal symptoms. And this is an example of what a color plot of an impedance tracing would look like. Here, the lower color means lower impedance. So when you see the darker purple color, that represents liquid. And here, whenever you see the LS, that's when we give the patient a liquid swallow. And you can see on the left-hand side, the purple color kind of lingers after the swallow. So the patient is not able to clear this bolus of liquid. Whereas on the right-hand side, you can see the clearance with swallowing of this liquid bolus. So in addition to looking at the actual pressure data of the esophageal body, we can actually now, using the combined technology, to see whether or not liquid boluses that we give the patients actually clear the esophagus with each swallow. So this is what an example of a combined manometry impedance study would look like, where you can see these peristaltic contractions that corresponds with clearance of the liquid boluses at the same time during the swallow. So how exactly do we interpret these esophageal manometry tracing? The standard currently employed is the Chicago classification. And the way we employ Chicago classification is that we look at these test swallows, usually 10 liquid swallows that we perform during manometry, and we actually analyze each swallow and score them using different parameters. And then there's an algorithm that we can go through that will help us arrive at the different esophageal motility diagnoses. So I'm just going to show you quickly how we would approach this. First of all, when we look at a tracing, this is an example of a swallow, one swallow on an esophageal manometry tracing. We first need to identify the anatomical landmark for, first of all, the lowest esophageal sphincter pressure zone that you can see here, as well as these diaphragmatic pressure. And we know that the bottom contractile pressure at the bottom corresponds to the diaphragm, because whenever it contracts, it correlates to changes in pressure in the thorax. So you can see different shades of blue in the middle throughout the whole study, and that corresponds to different breathing pattern. So we know that the contraction that corresponds to this breathing pattern is the diaphragmatic pressure. And in this patient, you can see there's a small separation between the lower esophageal sphincter and the diaphragm, indicating a small hiatal hernia. Another landmark that is useful to identify is when the swallow starts, which is when the upper esophageal sphincter starts to relax. So you can see here in the upper esophageal sphincter pressure zone, you can see a drop in pressure indicating this opening of the upper esophageal sphincter. Another important landmark that we identify is when the contraction, when the swallow ends. So there's something called contractile deceleration point that we identify here. This you can see is when the contraction, the peristaltic contraction down the esophagus ends, where there's a change in the slope of the contraction. And that indicates the end of an esophageal peristaltic contraction. One important parameter in evaluating esophageal manometry is the parameter called integrated relaxation pressure. This measures the relaxation pressure at the lower esophageal sphincter during a swallow, as you can see here with the box I identify. And really during the study, we can actually put a pressure box at the level of the lower esophageal sphincter during a swallow to see what the pressure is during a swallow. Obviously, if the relaxation pressure is high, meaning the IRP is high, then there might be a disease that's causing a poor relaxation of the lower esophageal sphincter with conditions like achalasia. Another parameter we look at is something called a distal latency, which is basically the time between the beginning of the swallow and the end of the swallow. And this is important because it tells you how quickly the contractions go through the esophagus. Remember, with peristalsis, you're looking at sequential contractions down the esophageal body. If that contractions go through too fast, then it becomes more spastic swallow when the whole esophagus contracts at the same time. So with distal latency, you're looking at a longer distal latency being normal. If it's too short, then you're thinking about some sort of esophageal spasm. Another parameter is the peristaltic break, and this corresponds to this transition zone towards the top third of the esophagus. This is where the skeletal muscle fibers from the top third of the esophagus transition into the smooth muscle fibers of the distal esophagus. And during that transition, sometimes there might be a decrease in pressure. That's a transition zone where there's basically a crossing of these fibers. It is normal. We see this peristaltic break in everybody. But if it is too large, that might actually affect bolus transit because you may have a loss in contraction in that segment. And finally, the last parameter that's important is something called distal contractile interval, which actually look at how strong the contraction is. So we basically measure this parameter looking at the distal contractions fragment of the manometry, and it tells us whether or not the contraction is weak, normal, or hypercontractile. And after we measure these parameters with each swallow, then we can score them according to different values. For example, with DCI, we look at whether or not they're ineffective versus normal or hypercontractile. With the distal latency, we want to see if they're premature, which means that they might be spastic versus normal. The peristaltic break, whether or not it's too big, it's fragmented. And the relaxation pressure tells us whether or not there might be outflow obstruction in the esophagogastric junction versus a normal IRP, which is on the lower side. And with these numbers, then we can employ Chicago classification to allow us to arrive at the diagnosis of these esophageal motility disorders. The current version of Chicago classification is version 4.0, which just came out actually earlier this year. And with this algorithm, we start with looking at the median relaxation pressure, the IRP of the 10 wet swallows. If this is abnormal, which means that it's high, and there's no normal peristaltic contraction within the esophageal body throughout the study, then it qualifies as one of the 3 types of the achalasia. And this can be type 1 achalasia, where we have a non-relaxing LES plus all failed contraction in the esophageal body, or type 2, where you have the simultaneous pressurization, you can see here, together with a non-relaxing LES, versus type 3, where you have the spastic contractions together with a non-relaxing LES. What if you have an abnormal IRP, but you do see some peristaltic contraction? Or if you have a normal IRP, but you change the patient's position and you measure it again, and then it's abnormal, but there's normal peristaltic contraction. So different from achalasia, where you have no peristalsis and abnormal IRP. This, you have abnormal IRP, but some peristaltic contractions. In the last version of Chicago classification, it will automatically qualify you for diagnosis of esophagogastric junction outflow obstruction. However, with clinical care, we realize that we're actually overdiagnosing these patients quite a bit. So now we actually require more supportive evidence to make this diagnosis, including looking at whether or not they have something called increase in intrabolus pressure that would identify an obstructive pattern, or supportive evidence like a delayed time barium swallow or abnormal flip analysis. If they don't satisfy the criteria, even if they have abnormal IRP, that would still not be consistent with EGJ outflow obstruction. And this is an example here where you can, on the left-hand side, you see a high relaxation pressure together with these increased pressurization in the esophageal body that consistent with EGJ, versus on the right-hand side, you don't see the same pressurization even though the IRP is high, which on the right-hand side is more an artifact and doesn't really qualify for EGJ outflow obstruction. What if you don't qualify for either of those conditions? And what are you looking at? You have a normal IRP, meaning normal lower esophageal sphincter relaxation. Then the next thing you look at is the esophageal body peristaltic pattern. And this may qualify for one of the 4 different disorders of peristalsis. And this include absent contractility, when there's absolutely all failed contraction in the esophageal body. Frequently, you might see these in patients with conditions like scleroderma. If you have a lot of spastic swallow, like here, you might qualify for a condition called distal esophageal spasm. If you have a lot of high contraction peristalsis, meaning the DCI number is high, then you might qualify for one of the different subtypes of hypercontractile esophagus. Finally, on the other hand, if you have a lot of swallows that are ineffective, meaning that they're either weak or they're failed, but you see some contractions, they're not all failed or absent, then you might qualify for ineffective esophageal motility, which is one of the diagnoses we see very often in patient with FORCA disorders, probably one of the most common findings. And if you don't qualify, a patient doesn't qualify for any of these diagnoses, then maybe it's a more normal study. So just as an overview, this is basically the whole algorithm that we go through with each manometry study to either classify patients to having one of the disorders of EGJ outflow or one of the disorders of esophageal peristalsis. Now, in addition to these conventional measures, the newest Chicago classification also suggested doing a number of different supportive provocative maneuvers using manometry that may also help us diagnose these patients. And these are a number of these provocative maneuvers that have been suggested. The two that are more commonly performed more routinely are the multiple rapid swallows and a rapid drink challenge. So what is the multiple rapid swallows? The multiple rapid swallow response is really a measure of esophageal contractile reserve. And what we're looking for is that with each, normally when we have patients take a swallow, and the patients take very quick successive swallows, while they're taking these swallows, there should be no contraction within the esophageal body until the last time the patient takes a swallow. Then after that, the patient generally should mount a high contraction swallows to basically compensate and clear everything that's been sitting in the esophagus while the patient is taking these quick successive swallows. So this maneuver is instead of these single swallows that we normally do with the test swallow, we also do a sequence where we basically tell the patient, we give them liquid and have them take 5 successive quick swallows in a row. And then we basically measure to see whether or not there's inhibition of contractions during the rapid swallows and whether or not after the last swallow, there's a high amplitude contraction that should be higher than a single swallow. And they are able to mount that. That's a positive response, indicating an intact contractile reserve of the esophagus. And why is this important? Because there have been actually a number of studies that have identified patients who have a negative MRS response or an absent contractile reserve may have a higher reflux burden if they have ineffective esophageal motility plus absent reserve. We have done a study that found that they have more severe reflux. And more importantly, in patients who are pre-out for frontal plication, if they have an absent in multiple rapid swallow response, they're more likely to have post-frontal plication dysphagia and esophageal dysmotility. So it might be something you want to look at when you look at a manometry tracing when preparing someone for potential anti-reflux procedures to determine whether or not, one, whether or not you want to tailor the study if they have a negative response, and two, whether or not they are even a good candidate if they have also very severe ineffective motility. The rapid drink challenge is another provocative measures that we often do to actually help us further identify esophageal dysmotility. This, we give them a rapid drink of 200 cc of liquid during the manometry, and they have to very quickly swallow these 200 cc of liquid. And normally, what we expect is that when they're swallowing really quickly to clear this 200 cc of liquid, there should be relaxation of the LES and no contractions in the esophageal body until, again, the last swallow, then they should have a normal contraction at the end of the rapid drink challenge. And that's a normal response. If you don't see that, or we see other abnormality during the rapid drink challenge, it may indicate an underlying esophageal dysmotility. And why is this important? Because it may actually help us further distinguish different Chicago diagnoses or identify dysmotility when patients present with symptoms, but when you go through the algorithm, they don't come up with a clear-cut diagnosis. For example, in this case here, you can see there's no contraction in the esophageal body, and then the relaxation pressure is kind of borderline. So is this absent contractility or is it type 1 achalasia? Well, if you do the rapid drink challenge, you can see these pressurization throughout the esophageal body when the patient is drinking this liquid, indicating some sort of obstructive pattern. This would suggest that this is more likely an achalasia over an absent contractility diagnosis. So it might help you with these borderline cases. Another provocative measures we often do is actually having patients take solid swallows instead of liquid. And it has been shown that it may identify more motor abnormality, like giving you more diagnosis of spasm or IEM that the liquid swallows may miss. So it might be provide some adjunctive data to the standard liquid test swallows. And finally, the last one is this postprandial meal challenge that we sometimes do. What it is that it's an extended study that goes out to 30 to 90 minutes. We have the patient, we'll put the manometry impedance catheter in. We have the patient eat a full meal, and then we keep monitoring them throughout. And it might help us diagnose something called rumination syndrome. And what we would see with rumination syndrome is that there will be a sudden increase in intragastric pressure, followed by the impedance showing these intragastric content, the food that you just ingested, coming all the way back up. That will be diagnostic of rumination syndrome. And this is an example of what it would look like on manometry, where you can see these increase in intragastric pressure, followed by on impedance, you can see these content coming back up in patients with rumination. So a quick summary of what we talked about today. Esophageal manometry is indicated for diagnosing abnormal motility, identifying anatomical landmarks. It helps to place pH or pH impedance catheter, helps us evaluate for contraindication to surgery, and also prognosticate outcome to surgery. It can help us using Chicago classification, identify primary motility disorders. Remember, with the new classification to diagnose EGJFO obstruction, we actually need some adjunct information from other testing like esophagram or flip analysis. Some provocative measures may add to the esophageal manometry to help us with the equivocal diagnosis and increased identification of esophageal dysfunction. For example, the multiple rapid swallows that we talked about, the rapid drink challenge, or the solid swallows. And finally, doing a postprandial meal study may, with combined impedance manometry, may help us diagnose conditions like rumination syndrome. Thank you.